I'm Hiran Fernando. I'm Professor-in-Chief of Thoracic Surgery at Boston University. I'm on the editorial board, and I've been on now, I believe that this is my 4th year with the editorial board. Young authors, often residents and fellows, will start is doing a case series from their institution. And I would caution someone who's about to start on a project when they do this to try and really optimize their data collection. And so they should review what's out there in the literature, see what kind of questions or issues related to the project have been addressed in the past. And this will help them in terms of constructing the data fields that they're going to then use in their data collection. They should really try and come up with a hypothesis beforehand that they want to try and show this, or show that they were able to improve this, or show learning curve. And again, that will help them to tailor their fields when they go through, because it's a lot of work to go through charts, and you need to really think about what you're going to collect and how you're going to spend your time collecting, and then how you might analyze it. Once you get to the point of writing it, try and present your data well, and present the results clearly. Try and present numbers rather than percentages, because it gets confusing when people just put in percentages. And then when you come to write your conclusions, conclude the data on conclude on what your data has shown. Don't try and extrapolate your data. Just make the conclusions of what you've shown, and then bring in these other things for discussion. I think it's really related to some of the things I've said, that sometimes the methods are not clearly stated. Sometimes methods are mentioned in the results section, and sometimes results are mentioned in the concluding section. And I think clearly separating those things can be helpful. And I think, again, using numbers rather than percentages. So when you're reading things, understand what the numerator is and understand what the denominator is, so that you can really understand the study group that's being reported. Specifically in lung cancer, it's how to take minimally invasive resection and perhaps make it more minimally invasive. And so by that, over the last 10, 20 years, we've seen a transition from open lobectomy to VATS lobectomy, and now we're trying to make it more minimally invasive. And so there's the use of the robot, the use of uniportal lobectomy, and then even robotic uniportal lobectomy. And this meeting, we had a discussion about micro lobectomy using very, very small ports with a subxiphoid approach. And there are even folks who are doing a completely subxiphoid approach. And then in other areas, we have people who are now starting to develop bronchoscopic probes that can be placed with navigation, placed into a peripheral lung lesion, and then we'll have the ability down the road to be able to cook these lesions. So there are a number of competing approaches that are coming in, which are all minimally invasive for lung cancer. When you have a patient with lung cancer, or any kind of cancer, it's very concerning to the patient. It's something patients have to struggle with, their families have to struggle with. And I think it's always, it gives me satisfaction to be able to help them with their diagnosis, help them to understand what they're about to face and the tests that they will need to go through. And then being involved in research and being involved in academic medicine and then with the editorial board, to really be able to present the outcomes from different therapies and options to the patient, but to try and present it in a way that they will understand and help them through this. And to me, that's always a rewarding part of the practice. In line again with some of the things that I've been talking about, I think one of the big challenges in coming down the pipeline for lung cancer is the role of SBRT and resection for those patients who may be candidates for both options. And I think that we've had an attempt trying to do a randomized trial, and actually there have been 3 attempts at trying to do randomized trial that have failed, because patients simply don't want to be randomized between a very aggressive therapy, such as surgery, and a less aggressive therapy, such as SBRT. So a group of investigators have now got together, and we're about to do a trial using something called randomized consent, where we think that we'll be able to get patient agreeing to participate in this trial. And I think it's such an important study that we need to do. It's not going along the traditional route. And I think now we have the funding for the trial. We're getting sites on board. And what I'd like to see down now is the trial moving forward and trying to keep the momentum with that. And that's really going to be a goal of mine over the next few years, to see this trial come to fruition.